Sure,
Yes, sir.
Sumitra.
Thank you, sir. So, a very good evening, everybody. I welcome you all to the Ask Me Anything series. So, for today's session, we have with us Dr. Paul Ramesh, so who is a senior consultant cardiothoracic heart and lung transplant surgeon in Apollo Hospital at Chennai, and he is also an adjacent faculty at Department of Mechanical Engineering in IIT Madras. And this is Sumitra from HTIC. Now, I would like to invite the chair for today's session, Mr. Sanjay Srivaksa, who is a strategic advisor, former CEO, business head, and board of director at Mahindra World City. So I'm happy to hear. I'm happy to see you, sir. So please go ahead with today's session proceedings, sir. And we would also request you to introduce the speaker and set the opening remarks for the session, sir.
Sure. Thanks so much, Sumitra. Good afternoon, good evening, everyone, depending on wherever in the world you are joining in. Yeah, my name is Sanjay Srivastava, and it's my privilege on behalf of ITM, Health Tech Incubator Accelerator, uh, all the other collaborative incubators, accelerators who are working together with ITM, STIC, and the participants to welcome you, Dr. Paul Ramesh Thangaraj. Thank you so much, and uh, it's a privilege to have such an eminent person who would, I'm sure, would have been extremely tied up in midst of what would have been a very busy schedule. So, thank you first and foremost for giving us time and to have a context. Dr. Paul Ramesh is one of the most eminent experts in the area of cardiothoracic heart and lung transplant surgeon. While he's based in Chennai with Apollo Hospitals, but he's been doing a series of work. He's been associated with a lot of eminent organizations across the globe. He's also an adjunct faculty at the Department of Mechanical Engineering, IIT Madras, besides his other responsibilities. And I think a lot of young entrepreneurs, startups who are joining in, it should also motivate you to have someone of his caliber, one, of course, to answer the question, but also to see the diversity of his engagements and how he would be managing so many balls up in the air, which is what I'm sure all of you startups and entrepreneurs are doing. And Dr. Paul, as you were asking earlier, I think ITM STIC over the past few years has really
Sorry,
curated.
I lost you in the last bit. Yeah.
Sure.
Thank you very much. Anyway, very kind
Yeah,
introduction.
my pleasure. So, as I was saying, ITM, STIC, along with BIRAC, along with the other incubation cells, have over the past few years has really been leading healthcare, health tech incubators and accelerators. Almost, I would say, as a movement. In fact, last year they were nominated as the lead agency by Department of Science and Technology to also conduct a national program for technology and business entrepreneurship for all the startups across. And this is just one of the things which they've been doing. Besides the startups and the entrepreneurs who are already logged in, I think there's also a list of some very good queries which have come in, and as and when Sumitra gets an opportunity, she'll also share some of those in the chat box. It will be great to have your perspective. So maybe as an opening comment, I think uh, everyone thought that 2020 was a year like no other, but 2021 has also been like that. And just in the first week of Jan has passed, and still it seems things are changing. And I think the important aspect is it has really brought healthcare and well-being right into the heart of everyone's awareness, and
Quite right.
possibly, yeah, and possibly you would also be seeing some of these trends where maybe earlier people would possibly postpone to meet specialists like you till the last or the last stage possible, and then say, okay, not what I do. So since we are just in the midst of a third wave, it will be good to have an initial impression that how are you seeing the evolution of the COVID across these waves and across these last 2 years.
Thank you very much. Yes, that's a very important aspect of all our lives, and I think you put it very rightly when you said that the what was fairly well known among the medical, or at least the critical care community, and I'll explain a little bit of what I mean by critical care community in a bit, is now some of the jargon, the way we interact, our thinking is now much more widespread, and even the average person on the street and other professionals are now quite cognizant of what exactly happens in ICUs. So this has really been quite a remarkable and extraordinary 2 years of my career, which is now in its it's in its 30th year. So this 30 years, these last 2 years have been remarkably quite something. Now, as far as I'll first kind of tell you a little bit about critical care and what it tends to do, because that itself is misconception, and then I'll speak a little bit about my own experiences with COVID, continuing experience with COVID. Now, as far as critical care services are concerned, or the area of critical specialty is a very interesting. Incredibly, its origins can be traced back to the 1918 pandemic, when people first invented the negative pressure lung, or what's called the iron lung, as a means of keeping people alive. Because quite similar to our COVID, the influenza pandemic of 1918 also was an acute respiratory illness. And people began to think that maybe hospitals were not just places where you went in with chronic illnesses. Usually people who went in with acute illnesses in that time period usually succumbed to them. People did not have protocols, did not have a method of resuscitating patients who are very sick. So the origins of critical care actually lie in a pandemic, and now it's, I think, quite appropriate 100 years on the next pandemic that we're talking about how to take it forward. And this has highlighted what actually happened. So one of the main things that or the feeding streams of patients into a ICU is somebody who's come into the emergency with, say, a heart attack or breathlessness or a stroke or a massive clot in the lungs, or whose kidneys have suddenly stopped working. So they present with a variety, and of course trauma from road traffic accidents or other kinds of industrial accidents or domestic accidents. So all of these people present to an emergency room, and so the people are triaged there, and then you find that some of them can be discharged within 24 hours. Some of them just need some observation. Some of them need to be admitted to a ward for a few days. But a small but significant proportion of those people will require further intervention and further intensive care. So that's one of the primary sources from which patients come into a critical care ICU. The other thing is post surgeries, where any kind of surgery where the patient has either had a very difficult time in the operating room, or even before going into the operating room, they were very sick. So in the past, when I mean past, in the 20 or 30 years ago, they used to be isolated medical intensive cares. There used to be surgical intensive cares. And this has got more and more specialized, because then we had pure coronary care units where they just took care of people with heart attacks. But what has been the realization is that multiple streams have to be involved in looking after patients. Looking after a patient is not the purview of only one specialist, but multiple specialists. This also brought the added problem of integration and communication, because unless you had a funneled approach with the multiple specialties coming together, the care was not fragmented, but I would say it was siloed. So the nephrologist would come and give some kind of advice, and then the pulmonologist gave some other advice. So the a kind of evolving position of a critical care consultant would be someone who would funnel this care and would look at priorities, which also meant that their knowledge base had to increase tremendously, because now they had to look into multiple specialties, and each of these specialties has been growing at quite a tremendous pace. I'm talking not just in terms of knowledge, but also in terms of technology and the use of technology. And a lot of physicians and surgeons sometimes feel a little outstripped by the speed of technology. Not all the technology is actually particularly useful. So this is the background of critical care. As far as the COVID is concerned, we are looking after the COVID ECMO ICU. So the ECMO is represents a very advanced level of looking after lungs, where you take the blood out of the patient and you improve both the, I mean, you give it oxygen and you take out carbon dioxide, and then you send it back into the patient. So this is really done as a way of keeping the patient alive, because once your lungs don't work, so lungs is a very, very important interface. If you think about a single celled bacteria that is, say, floating in the ocean or in the air, it can take in gas exchange with the environment directly through its cell membrane itself. But we as human beings or primates and a lot of the multicellular organisms need an interface by which we exchange gases. For us, it's only the lung. So if the lung is failing, you cannot give out the carbon dioxide, which is the end product of you breaking down your foodstuff and getting energy, or taking in oxygen in order to break down the foods. There are two kinds of lung failure. You can have lung type 1, where it's a pure oxygenation problem, and type 2, where it's a combination of both the inability to take in oxygen as well as to clear out carbon dioxide. So this is what the ECMO does. So as far as the COVID is concerned, we had in the first wave, we treated about 4 or 5 patients. This is a very esoteric piece of equipment which we have been using for the last 10 years, largely for patients, because we run a transplant program who had very bad lungs, whose lungs failed, and we would use the ECMO as a way of bridging them to transplantation, or a patient who had a sudden cardiac arrest or came in with poisoning or some other event where the heart and lungs were not working. We were using this. So we had an experience of about 270, 280 ECMOs prior to the pandemic. And so we expanded this. But we came into our own really as an independent ECMO COVID ICU only during the brutal second wave. And that was a really, I had never seen anything like it. It's only because of the sheer volume of patients who ended up coming into the ICU. So on an average day, I would have something like 30 or 40 referrals to the ECMO ICU. So you have to understand that a patient could come in, feel a bit breathless and go away, but then they might also end up requiring ventilation. And then if that doesn't work, they may end up requiring ECMO. So this has been our experience so far. And I now welcome any questions on this or any other subject related to critical care.
Sure. Thanks so much, Dr. Paul Ramesh, for sharing this. In fact, one of the questions I thought it may be of interest, since we have a lot of startup entrepreneurs, is, and I had seen some of this, that during the second wave, we also saw many of the healthcare, health tech startups, as well as some of the other startups who are working in the area of engineering or auto ancillaries, trying to pivot some of their engineering skills to maybe come up with some innovative solutions by which you can actually do sharing of oxygen cylinders, or by some other way create a cost effective ventilator. It will be very interesting to know if you came across some of these innovations in the startup space, and what was your experience?
Yes, very early on during the second wave, there was a lot of enthusiasm, I should say, from engineering people who felt that they could contribute. And I think this spirit was actually quite the right thing to do. Obviously, at that time, there was a lot of confusion about who would do what. And I had been approached by about by one quasi-governmental agency, as well as 2 other completely independent private, as to, and they were all focused on ventilator. So what actually happens in an ICU is that you have to have the technology for monitoring patients, because that will tell you early on. For example, let's take the example of COVID and lung itself. If you are looking at someone's oxygen saturations, we have in the ICU something called a blood gas machine. but we also have something called a saturation meter, which is essentially infrared technology, and it helps or near infrared spectrometer, which tells you how much of the hemoglobin in your blood has oxygen. And this was used as a very important value. But there are serious limitations. I can speak to you about NAS as to why there is a serious limitation with this in very sick patients. However, that was one area in which people were interested in. The other is what you mentioned, whether they could split an oxygen tank into two, whether a same ventilator could be used to ventilate two patients. And these were not possibilities. I'll tell you the reason why. Two different people are two different people. Their lung volume and their lung compliances are different. Their requirements of oxygen are very different. So in order, then there was a discussion about could we have flow meters and some kind of software and feedback to the flow meters to say, okay, if patient A required, partial pressure oxygen of 60% and the other person required 100%, could we split that and send? But the problem was if you were going to have the same ventilator or the pumps inside the ventilator machine pumping out the air, you would have to pump out different volumes of air to the two different patients, and that was not possible. Then they said, oh, could we have two pumps? But then it essentially became that you had to have two different ventilators. So some of them, while certainly very enthusiastic and very appreciative, were really not possible to implement at the ground level. And of course, there was also the sharing of infection and other things between two patients sharing a ventilator. So those were some of the other issues where we came against a roadblock.
Sure, no, fair enough. That's very interesting. I have some few follow-up questions, but what I would do is, so we would like to keep it really interactive. So let's first start picking up some of the questions from the participants who are there. And once again, an announcement, as Sumitra said at the start, all the participants who would like to speak and ask your questions, please do either put it in the chat box or raise your hand. I will call them one by one. If someone is unable to use their microphones, then please do leave the questions in the chat box and I'll pick up on your behalf with Dr. Paul one by one. One of the first users participant who wants to ask the question is Umesh Chandra. Umesh, can I request you to unmute yourself and please do a brief introduction about yourself and ask the question?
Yeah, hi. Hello, everyone. This is Umesh. So my question, focus of interest in this thing is with regarding to regeneration of heart. So actually, my father had an heart transplant this last February. He did not survive it. So the heart got rejected. So I tried futilely take him to people in Göttingen, Germany, where they work on primates and all for replacing hearts and all, but that wasn't possible. So it occurred to me, why can't we develop a digital twin of the heart so that even I'm an engineer, so I do not know anything about about the biological issues. There are many things. I mean, it's a very vast literature. I have gone through the literature. I even have to learn a lot about stem cells. I mean, basically a cell, how does a cell work and all, and how these protein markers, how they interact with each and everything, and what actually causes. I mean, it's like a clockwork. Like one thing leads to another. So why can't we make a digital twin? I mean, if you had heard about cellular automata, basically, do you know, sir? Did you hear anything about cellular automata? It's a finite state machine where you code in the initial parameters and the system.
Yeah. Question. I think some of the users are facing a bit of audio disturbance from your side.
Okay, fine. Basically, it's a cellular automaton is a finite state machine, and when you key in the parameters, it evolves, the system evolves. So based on this logic, can we like make a digital twin of the heart, like in a software where you can visualize, and you can all the other people can collaboratively update their rules and other systems, other knowledge.
Yeah,
Thank
so
you.
my understanding of this cellular automata is that it's a software that is continues to update. But what would you use as the actual mechanical interface? Because let me tell you a little bit about the background of the heart, and then I think we can discuss your question in specific. As far as the heart is concerned, the people just think of it as a pump, but it's actually a pretty coiled, twisted pump. And it's a very, very interesting organ. Just to mention to you that people have been researching in this particular area of how to make a material equal to what is called the myocyte sheet. So our myocyte is just the cardiomyocyte is the heart muscle, and it is not actually like a striated or skeletal muscle where it's completely voluntary, or like your intestines, it is not completely involuntary. It's kind of somewhere in between. So it is also a cellular network. So an individual muscle fiber in, say, your biceps is just one single muscle fiber. Whereas there, it will be a network of fibers interacting with each other. And the background of stimulating the heart is there is an electrical component, which comes from the pacemaker of the heart called the sinoatrial node. So this one generally has a lower threshold at which it fires. So therefore, it fires before any other part of the muscle of the heart. So because it fires first, it is able to take this kind of impulse into multiple areas. So there is first SA node, and then there is a part called the AV node, where you find that it is another junction. It is slowed down a bit, and then the final impulse is sent completely into the ventricular muscle. They coordinate together through this intercalated network, and then the right and the left ventricle squeeze just a little fraction of a millisecond after each other, so that they tend to empty out the same. So it is actually, if you look at it from a mechanical engineering perspective, it is both a series as well as a parallel system. And so therefore, there is some complexity involved in how both the ventricles interact with each other. Now, I will tell you some of the, so we have, they have tried stem cells. Prior to that, we have been actually exploring xenotransplantation for over 30 years. I myself was involved peripherally in the research in the early xenotransplantation program at Cambridge. Today, as it happens, is the news is that they have actually transplanted a pig and he's been alive for 3 days. The issues with this will come with rejection, even when you actually accept for an identical twin. So an identical twin is not just any twin, but when the mother's zygote or ovum is fertilized, they are both fertilized in the same kind of egg, so that they are absolutely identical in terms of their immune system. Only there you will not get rejection. Now, your cellular automata, coming to your cellular automata, I'm not exactly sure what is the interface between your software and the mechanical aspect producing the actual pumping. Is there some kind of special material that you use?
No, and I'm not talking about any like hardware or any like living thing, tissue or anything. Let's say you said all this, but I don't understand any of this, and a picture is worth 1,000 words. So why can't we make a software where we can visualize all this and it can be used as a teaching material?
Yes,
what
I
are you?
That certainly, I think there are lots of very useful learning materials, but at least as far as surgery is concerned, it is still a very apprentice-driven kind of training. So it's not, you will have to operate, you will have to stand next to the patient, and it's quite unfortunate about your father, but rejection usually for the hearts are much less lower than lung transplantation. However, it does occur, and it is due to a variety of reasons. Yes, to answer your question, you can have a variety of teaching aids that help people understand.
Okay.
Thanks so much. Thanks for your question, Umesh. To move on to the next question, we also have LifeGraph Biomed. You want to go ahead? Please do go ahead.
Very good evening, sir. I'm lucky that I'm getting such kind of interaction with you, sir. Also, so basically, I'm a startup boy. I'm developing one small device to monitor IV therapy, intravenous therapy. So my question is that what can be damaged when IV fluid bag become empty? Yeah, you overdose, no flow. There any chance of backflow of blood? This is my question.
Yes. Yeah, that's actually very, very important area, because IV fluids are used almost universally in ICUs and wards. So we have two problems. One is from the medical side, accessing good veins, especially patients who are very chronically unwell, who have had multiple times they've had IV fluids, or they have a disease which produces clotting in the veins, or cancer chemotherapy drugs, which and certain other kinds of drugs which can cause irritation along the veins. All these lead to the fact that there is a finite amount of times you can prick somebody and get a vein. Now, as far as your end of it is concerned, the actual machine that delivers it, there are two or three issues. One is that there has to be a very accurate, and compared to when I was a medical student in the late 80s, it is remarkable, these new digital and artificial, especially in terms of the insulin pumps and other kinds of syringe pumps that we have now. They are so intuitive to use. There is a small amount of what I can only call AI, where it resets itself. So there is a fair amount of improvement in technology over the years. This is something that I've seen myself evolve over the years. So accurate estimation, alarms that bleep, not all the time, but when some problem is going on. And you mentioned one, backflow. So whenever the pressure in the vein becomes higher than the pressure of the ability of this to push in, that's because some clot has formed, or the end of the needle has come out from the the inside the lumen, or it has slipped out. So the fluid is now going into the tissues rather than going into the vein, or blood is coming backwards because maybe the heart is failing, the pressure in the veins is building up. All of this leads to an inability to give your whatever medicine you're giving, and that can be dangerous in itself, especially if it's something life sustaining like adrenaline, noradrenaline. So you got to make a difference between just a little bit of fluid going into the patient and very, very important drugs going into the patient. The other thing is that air getting into the system is very important. It may not matter if it's very tiny bubbles, but if you have large intravenous drips going into the central veins of the neck, say your superior vena cava, internal jugular vein, these are very big veins, and they work at pressures typically between 0 and 5 millimeters of mercury. So any air can get entered into the system, a large enough air, or even a small group of bubbles that can get together and go into the right side of the heart, can get into the lungs, the pulmonary arteries. So that is what we call air embolism. And that is, if it is big enough, it's fatal, because no blood can flow beyond that. So no blood will get to the lungs, and the patient can quite die. So the areas where I think some level of development can come is in early alarm systems for bubble. We have this to a large extent in heart-lung machines, where we take massive pipes and drain all the blood like ECMO machines. They have extremely sophisticated bubble sensors, which come incorporated with the machine. But you don't have it for IV systems. So that's an area that you might look into. So.
Okay, sir. Thank you so much, sir. I got my answer in a very precise way. So better, sir, can I get your email ID for this discussion in detail? Means I want this scriptural thing, what you said right now, because it is very important for my product validation, what you said right now.
No problem. I will share my email with Sumitra. You can get it from her.
Okay. Thank you so much.
Yeah. Sure. Thanks so much for answering that question. One of the questions, Dr. Paul, I have is from, in fact, two of them from Remcos Technology. Mr. G. Ezil Krishnan, the co-founder and the director, is there. It is one of the companies getting incubated at ITM STIC. And his first question is that the care for elderly with comorbidities like diabetes, BP, especially at COVID-19 times, requires a trained staff to reduce the pain and suffering. So how do you advise that? And I think the second question is that there are a whole plethora of monitoring of key parameters, whether it is heart rate, pulse rate, PCR. There are good responses from this technology for getting the results, but still the critical ill patients typically have a longer stay in the hospitals. So is there a possibility by which this can be stay can be reduced?
Yes. Okay, there are two questions. The one is about the taking care of elderly patients with multiple comorbidities like hypertension, diabetes. So this is a problem of the aging population in general, even without COVID. Even if COVID was not an issue, there is both a societal as well as a medical problem. The medical problem stems from the fact that life expectancy has increased, but non-communicable diseases have increased, and the societal problem comes from the fact that most of them have children who are either working away from home in other states or even in other countries, and so therefore they are pretty much left to fend for themselves. So this there are two issues to it. Now you might have what is called worried well, or somebody with comorbidities but who's stable, who can be at home. How do you monitor them? My mother is all alone at home in Mylapore. I am in America. How can I look after my mother? So yes, you can plug in, as Dr. Srivatsav said, you can plug in a variety of monitors to look at BP, oxygen saturations, and this can be conveyed in real time to the child, or I mean to the son or daughter living in the US, and they could communicate, or you could have like a medical program that can immediately send an ambulance and get them. This in theory sounds nice, and it is kind of being tested in a few countries. The problem is one of volume. If you look at the elderly population and you stick them all with sensors, where is we don't have the medical infrastructure or even the paramedical infrastructure to cope with this, because even now the governments have not invested so much in paramedical training. They do have some colleges. It is still multiple colleges, private colleges that open up for nursing and paramedical and all of these people, and the kind of standards of training are extremely variable. So you will end up always with the human element blocked when you're given so much information. What do you do with that information? More importantly, and this I'm coming at it from a knowledgeable, responsible corporate hospital, a responsible private doctor, we are exposed enormously to litigation. So for example, if we use this technology and say Apollo signs up, or even I as a doctor or my critical care group signs up, saying that we will take care of your mother if you sign up into this program, you can get the app and everything. But say that something is missed. Say there was an issue with the sensor which you can't really put your finger on, or there is nobody looking at it, or you're unable to send somebody in that given period of time, or even if you did all those things, the patient died. There will be a number of lawsuits in this particular area. Doctors therefore are very, very loath to take on looking at monitors and making decisions. So this is one of the reasons why I think even if the technology is available to monitor patients, elderly patients, or even other patients at home, I think you're going to find it difficult to cross that barrier without some larger legislation that protects the hospitals and doctors comes into the picture.
Sure, absolutely. So I think from a point to ponder for the startups or the entrepreneurs who are there is, how do you really balance the scale of opportunity available? From there you bring it down to targeted addressable market, because every single senior citizen, you can say, is potentially a target, but the real targetable or the addressable market is much lower, and along with maybe some caveats. So I think that is a very important aspect for people to keep. I've seen some very innovative things being demonstrated at the various showcases, and one of the questions which we often ask is, how do we ensure that it is compliant? Because when it is a small startup, it can be allowed, but moment an institution like Apollo or any other large hospital or a life insurance companies will adopt at scale, then it will require that kind of a support. So I think also you highlighted that the second factor, which is what is the kind of regulatory or the ecosystem which is there. And I think the third thing which plays in these situations is the supply side, that how do you really make these very reliable, as you said, devices at cost-effective manner, which can actually serve the purpose. So that's how possibly this triage of demand side, the ecosystem or the regulatory and the supply, they will continue to work together. We also have, let me move on to the next set of questions. We also have a few more people. One of the next persons we have is Shanta Kumar D. Shanta, can you please go ahead with introduce yourself and go ahead with your query? Shanta, are you able to hear us?
Hello, good evening.
Yeah, good
Hello,
evening.
sir.
Yeah, Shanti, you go
Yes,
ahead.
sir.
I was calling you next, but no problem. Please go ahead, Shanti.
Okay, sir. Sir, my question is actually I'm working as a professor in the private engineering college. Recently, along with my students team, we have started to design and construct one heart attack prediction wearable device, sir. Is it possible to bring that product, sir, as a wearable device?
Yes. So what? How does it detect early? What kind of things are you looking at?
Sir, actually, they are following 2 to 3 parameters based on the pulse rate, based on the blood flow, BP rate. They have already the hardware is established, sir. So, in our idea, along with machine learning concept, we are going to classify the what type of blood flow, where it is going to be occur. So, based on that, we are going to use classification algorithm. As well as we have planned to include a few more parameters, sir. My question is, what if for parameters we have to give more weightage to detect the heart attack, sir?
Okay. So as far as heart attacks are concerned, right now, most patients come to the emergency room or tell their doctor that they have chest pain. So it's still symptom based, and after that we do an ECG, and after that we do certain markers in the blood. Their enzymes. These enzymes are not normally found in the blood, but when the heart muscle has been damaged, they leak into the blood, and so these are normal kind of proteins that are present inside the heart muscle. So these are the ones, troponin T, troponin I, troponin C, those are the normal ones. We look at it, and based on how they are, whether they've increased or not, we decide whether they have a heart attack. Now, over the last 10 years, as soon as somebody has a chest pain, they are actually, and if it appears to be that they're having a heart attack on an ECG, even if there is only a question of it, they're usually taken into a angiogram room and a stent is placed because of the concept of the golden hour. In that first 1 hour, if you are able to open up the vessel, you have a less chance of the patient dying from the heart attack or having severe heart failure. Now, so I'll come to this thing. If I'm not still very clear what is it that you're monitoring, but if you're going to be monitoring anything, you should see how it works in asymptomatic patients. So the first and foremost thing is you should have a trial. One suggestion I have is, if we can have a discussion later, is you can try this out in an ICU setting where patients are already extensively monitored. And so you can then see whether your particular device and your machine learning algorithm is picking up something earlier than current technology. There's no point in inventing a technology that is picking this up equal to everybody else. So where would this be? This would be patients who are in a hospital undergoing normal surgery or an ICU who are also prone to heart attacks. In fact, they are at a very high risk of getting a sudden heart attack. You may go for a gallbladder surgery and end up having a heart attack. So monitoring in theaters and monitoring in ICU would be the first step. Then you can take it to a general population at large, and you can then you have to place it in a lot of normal people, because biology, and this is one of the things my discussion, I've been an adjunct faculty in IIT from 2005. In my discussion with physicists and engineers, medicine and biology is not very black and white. There is, I think you can understand it from the statistical model of quantum theory. There is so much variability multiple possibilities are there in even if the same kind of disease evolves in different people. So therefore, if you must first show that your predictability in a given population is very good at picking up people who are definitely, that is, you don't have a high false negative rate with your this thing. Otherwise, you'll have a lot of people are having heart attacks, but believing your sensor, they will say, I'm not going to go to a hospital, I'm not going to get help. So that is a very important aspect. The second is false positive. You don't want to have too many people who don't have heart attacks who are going to be scared because of your sensor and keep running into hospital. That is also bad, but it's not as bad as false negatives. So first, you have to generate this data to show the sensitivity and specificity of your device in making the diagnosis. And you can do this through a set of trials, even in normal people and in ICUs and in anesthesia, patients under anesthesia, where we are monitoring the patients already. So over and above that, if you add your sensor and if it is improving, then it can be incorporated into the existing technology. Does that make sense?
Thank you, sir. Sir, as per your device, as per your advice, we need to go for survey, right, sir? We need to do practical survey.
Okay, yes. So what I would suggest is, because you're an engineering college, you get in touch with, we have a large clinical trial group in our critical care. So they will tell you there are certain aspects of how you would do a first phase trial, a second phase and third phase and so on. Since this is a diagnostic tool, the ethics committee should not have a problem. You're not giving them something and you're also not, so it should be fairly easy to pass through ethics committee. And that is a big major concern. And so after that, yes, first normal population, then population that is at risk in a hospital that is already being monitored, then you can take it to the general populations.
Okay, thank you, sir. Thanks for the clarification.
Thanks so much, Dr. Ramesh. What you're saying is almost like circles of concentric circles. So take the core, then increase the next level and next level, and that's how you can increase that. Very true, and that's the most sensible thing to do. Let me also pick up one of the questions which have come up in the chat is from Nidya Jogi, and the question is, could you please throw some light on common critical illnesses in pregnant women and newborn?
Okay. I'll first take the one with the pregnant women. So one of the things, particularly now, is especially in the second wave, when people did not have inoculations or vaccinations because they thought pregnant women are at risk, we saw a lot of pregnant women who ended up with COVID. The pregnancy, so I think it's a little necessary to know some basic facts. Pregnancy induces a actually immunosuppressed state in the mother, not a fantastic but some level of immunosuppression. And why should this happen? Because the fetus or the baby is considered like a foreign antigen. And so you don't want the mother's body start rejecting it, the mother's immune system. So the counter mechanisms in the mother's body actually reduces, so they have a higher chance of infection. So before the baby is born, they are prone to autoimmune diseases. They can have disease, any other disorders which could, and diabetes especially, and infections and things like that. They are more general cases. Very specific to pregnancy itself is, especially during the birth itself, there could be hemorrhage or bleeding. Okay, so because when the placenta, which is like the interface between the fetus and the mother, begins to tear out from the uterus, normally the blood vessel should constrict, and the uterine wall, which is a very phenomenal thing, it just constricts in and closes all these vessels. If for some reason that doesn't happen, then excessive bleeding, and I'm talking about torrential bleeding that can kill the patient very quickly, is a major critical problem. Then if the mother has had some background heart or lung disease, it could be exacerbated because the blood volume is now mother's blood volume plus fetus blood volume going through. So the heart has to do more work, the lungs have to do more work, so they can begin to fail. Then one particular thing is that the amniotic fluid, which is the fluid that surrounds the baby and nourishes the baby, can escape from that sac and get into the blood vessels of the mother. This can cause amniotic fluid embolism in the mother, and that is also an extraordinarily dangerous and it can be a fatal disease in the mother. So these are some of the things that are directly related to the mother itself. As far as the baby is concerned, it depends on, most of the time now we have extraordinarily excellent ultrasound monitoring of the fetus right from conception to the point it is being born, and I would put that as one of the greatest engineering advances as far as fetal and maternal healthcare is concerned, is the development of the bedside ultrasound. So this imaging technique will let us know what is happening. But usually if the baby is born preterm, then a lot of the organs are not matured. Particularly the lungs are not very matured. The liver is not very matured. So we have things like phototherapy, which reduces the jaundice. We have a recombinant surfactant, which is to reduce, because normally what happens is you produce a protein that reduces the surface tension, and you want the lung surface tension to be less because you want it to expand easily. If this is not usually produced in preterm infants, and so because of that, the surface tension inside the lungs is very high, and it tends to collapse very easily, and they have what's called infant respiratory distress syndrome. And this is a very important kind of disease that happens. So these are some of the simpler and more important diseases that happen in pregnancy and newborns.
Sure. Thanks. Thanks for that. Shanta Kumar D, I can see your hand still raised. Are you able to hear us? Then please do ask your question. Okay. Just maybe Shanta, you can put your question in the chat box if you're not able to unmute yourself for some reason. I think we have also have a follow-up question from Umesh. Yes, Umesh, please go ahead. You have a...
Hi. Basically, I'm an engineer. So how do I go about start pitching this idea to an investor, or how do I garner support from the medical community because last week Nvidia is a company that released a software called Omniverse where people can work in collaboration with different people around the globe. It's like developing your own game where you develop your software in 3D in a virtual reality space. So how do I garner support with the community? I mean, how do I what should my roadmap be like?
So this is for your twin heart.
Digital thing.
Right? Okay.
Yes.
Okay. See, the first thing you have to be is very clear what aspect of heart function is going to be. Like I said, the heart, there are multiple functions. One is the electrical aspect of the heart. One is the myocardial contractility part of the heart. One is the regulation. One is what's called the diastolic relaxation of the heart. All of these are, and then the systolic contraction, the flow, the circular flow. The right ventricle flows differently from the left ventricle. So there are multiple, if you want to break down the function of the heart, there are multiple ways in which you can break it down. So you have to first make it clear to the doctors, the medical fraternity of the investors, which aspect of the heart function you're going to study. Then the next step will come as to what is the current existing technology and what is your innovation going to either enhance the current technology or replace it, or it is going to be more cost effective. There's only three reasons why any investor might want. It is either better than what is there before, it helps improve the current thing, or it is much cheaper. So if all of these boxes are ticked, then I think it is always wise, as you said, to have a collaborator. For our research project, I study sepsis and systemic inflammatory response syndrome and gasotransmitters, hydrogen peroxide and hydrogen sulfide. I do it with a large team. There is Professor Muralidharan in chemistry, Ashish Sen. Now we are also in, along with Arun Tittai in the ultrasound department. In addition to we also collaborate with the Department of Biochemistry with the Madras University. We also collaborate with the Institute of Mathematical Science. And this is a very small project in the sense it is only about looking at two particular molecules and see how they evolve during extremely critical illness, especially things like sepsis, infection, SIRS. So something like what you are planning to do, which is like study the heart in detail. Now your software may actually enhance the 3D image coming from a cardiac MRI or from a cardiac ultrasound. If that is the case, then you have to approach the people who normally work on those areas and see what the current problem is in their imaging. Because I do know something about the cardiac echo. What happens is it is essentially Fourier transform and Fourier signal analysis. Even right now, based on what the ultrasound wave that is sent and what is got back, much of the information that they actually get back, they are actually not using it to construct the image at all. mainly because of constraints with the size of the machine and constraints with also the software, and also because it's not probably necessary. So I think if you are largely coming from a software aspect, and you want to think about imaging, I think approaching those people and seeing how much more information we can use from even current technologies, whether it's MRI, cardiac MRI, or echocardiography, ultrasound, I think that may be a starting point.
Are you telling about DICOM files, etc.?
Yes, I mean, it could be DICOM files is one aspect of it, but now they have a lot of, I think, far more sophisticated software that goes into, I don't know the details of the software that goes into imaging in cardiac ultrasound, but the more newer 3D machines are amazing in the reconstruction of the heart. And I remember a time when the images used to be extremely fuzzy and you could barely not make out much. And I remember surgeons that I worked with as consultant and myself as an early trainees actually ignoring the image and then going to what we knew clinically. But that's no longer the case. We now depend on it. But I was told by a senior ultrasound cardiac that they are still using very, very little of the actual information that they are receiving back from the ultrasound wave that's reflected. So.
So maybe I think that's also an area for possibly doctors and specialists to accelerate the technology adaptation, which improves it. Very interesting. In fact, I've also got the thanks, Umesh, for asking the follow-up question. Also, a question from Shanta Kumar. For some reason, he was unable to
Yes.
unmute himself. He's talking about that. They are actually making ultrasonic detectors regarding bubble detection in IV line, etc. So his question is, in the ICU, the typical monitoring parameters are ECG, NIV, SpO2, temperature, etc. Are there any new parameters required as the trends are changing?
So yes, so one of the things that now, because with the advent of ECMO technology, we are using far more levels of invasive monitoring in patients, and also the ECMO machine itself comes with saturated hemoglobin and PO2 and various other kind of sensors are incorporated into the ECMO machine itself. Because we now need to know far more important things. But there's always, you can always have more information. Now, I want to tell you that critical care and ICU is very data driven. The patient is usually unconscious, and so it's not like in an outpatient where you're talking to the patient, getting the symptom and having this feedback and making a diagnosis. The diagnosis in ICUs is largely data driven from monitors, from numbers, the trends of the numbers, and so on and so forth. To answer your question, even now, there are two aspects. One is the blood gas. So the blood gas is the partial pressure of oxygen, partial pressure of carbon dioxide, the bicarbonate level, the lactate level, and a few other things, and the pH. So these are very, very important and critical in us making a diagnosis of an ever-changing situation. So because one of the most important aspects of critical care is, are you delivering enough of the circulation in order to keep the tissues happy, the tissues within a pH range of 7.35 to 7.45. This is very important. If they get too acidotic or too alkalotic, there is a problem, especially if it gets too acidotic. If a patient is getting too acidotic, it also means that the amount of blood going to the final cell and the tissues is not adequate. So this is actually, by definition, this is what is called low cardiac output, or it's called shock. So monitoring this very early sign of shock is very important. So right now, we take a little bit of blood from the patient, we go to a machine, it's based on the Clark's electrode, and we do it there. That there is a problems with recalibration. It is still a technology from over 30-40 years. The sensors have got a little bit better, but the basic concept is still the same. If we could develop, and this is one of the things that we are looking at, is we have developed sensors with Ashish Sen's lab, microfluidic sensors for hydrogen peroxide, hydrogen sulfide, nitric oxide, but that is basic science research is our goal. So that's what we are doing. But if we could develop for oxygen, carbon dioxide, hydrogen ions, bicarbonate, and the idea is, I think the future as far as ICU is concerned is not take blood, get it to a lab and do it. You can do that as corroborative to whatever, but the more information you get at the bedside itself for a variety of things, magnesium, calcium, sodium, potassium, all of those things, if it can be got to the bed itself, not even to the bedside, not even to the ICU, you have to go and put it in a machine. It wastes a lot of man hours. The nurse has to take it, go it, the machine is not calibrating. There is one machine, people have to stay in line. So I think the development of that is going to be, in my view at least, the next kind of step forward, where all that you want monitored for the patient that is critically important, it's all done in the bedside. Currently, we do about 20% of what is required at the bedside.
Sure, absolutely. And I think that you have also given some very good pointers to Shanta, because his interest was that he would like to work on monitoring of some of these new parameters needed. So Shanta, now you know there is a Dr. Ramesh has given you the straight uh, answer on what is required. Now it is up to the entrepreneurs to show how this will work and really work it in.
Can I also just add one
No,
thing? I
please.
think as entrepreneurs, and I've seen quite a few over the last 15 years while I've been in IIT, from glass manufacturers to microfluidic experts. I think one of the things I have found where they are really good is somebody like yourself should come to an ICU. It's not everybody's cup of tea, very sick patients, but you can then, even if you go to the bedside of one very critically ill patient, you can see the number of things that are being monitored. So one of the other things is in a completely sedated patients to look at things like EEGs, look at neural this thing. These are very important. Is there enough blood going to the brain? At the end of the day, in the ICU, we are controlling the circulation. We are controlling the oxygen and gas exchange. We don't know how much of this is actually reaching all of the tissues. We have a reasonable idea based on urine output. We monitor the urine output. We can monitor the blood pressure and so on and so forth. But we're really looking at the pressure. Are we looking at the flow at the individual tissue level? No, we are not. We are making an indirect assumption based on the fact that the lactate's not building up. But if you could have kind of a tissue flow sensor for especially the vital tissues like the brain, the kidney, the liver, and so on, I think that would be very, very useful in the future to make decisions more quickly before end organ damage comes.
Sure, great. Thanks so much for the pointer. Dr. Ramesh, I am also aware of that we are just reaching about the appointed hours which we had. How are you doing on time? Can we take maybe just about 5 minutes? For you?
Yeah, absolutely fine. If just one, I just switch on the lights, so it's just got a bit dark from the outside. One second.
Please, please.
Yes, Dr. Srivatsa, please go ahead. I'm all right for time.
Okay, great, great. Yeah. Now, just to clarify, I'm not a doctor, so you can. I'm actually more. I work closely with the ITM team on how to help the business
Oh, I
case.
see.
Yeah.
Okay.
So maybe to respect your time, I'll just take the last two questions, and then maybe we can do your final comment. So one question is from Devendra Ghotki. He's requesting your opinion on difficulty in cannulating a peripheral collapsed vein in emergency.
Yes, very important issue. So what happens is the vein could be collapsed for a variety of reasons. Usually it's a road traffic accident, patient has lost a lot of blood, or the heart is not working very well and all the peripheral circulation has gone into spasm, or the patient has had multiple punctures in the past, and some patients, their veins are just poor. Or in some of the patients, they are quite obese. And because they're so obese, there's a whole lot of fat lying where the vein is going, and it's not easy for the doctor, especially a junior doctor who's on the scene, to be able to access the veins in a quick manner. So we get around this problem by putting a large vein into the neck. This used to be one procedure of requiring extraordinary skill experience when I was a junior doctor. Thankfully now again ultrasound has come to the rescue, so we can actually visualize it. And we can try and put it in. Now, there is some kinds of gizmos which I have seen and tried in the ICU, whereby there is a red kind of light gets shined on it, and then we mark where the vein is. They have not been particularly helpful. The problem with using something like to detect the flow and see if by detecting the flow, can we see where the vein is? In a lot of these patients, the flow is very poor. So that is another issue. So if you could get some kind of imaging, usually what we put is we put a tight tourniquet so that the veins kind of stand out, and we try to get one in. And there are some patients in whom it is extraordinarily difficult. So we will have to go directly into the neck or into the groin. So the femoral vein and the internal jugular vein are two large veins which kind of come to the surface, so we can access those veins. But getting peripheral veins which are collapsed are quite challenging in the ICU or in the emergency.
Sure, thank you. And let me pick up the last question from the participants before wrap up. It's from Shanti Govindraj, and what Shanti is asking is, how effective is the telemedicine role play in India? And especially in the COVID, we saw even the government came up with an ordinance which allowed telemedicine prescriptions. That was a significant breakthrough. So I think Shanti's question is, so what kind of support or what kind of engineering support which is required so that can this be adopted at scale?
Yes, there have been, I think even from IIT, Professor Junjunwala's unit some time ago had done a few things, what they call the cell or a kind of like a telephone booth where the patient went and had a variety of things done. I'll break this up into two. I think telemedicine is here to stay in a country like ours. I think it is very, very important. And how much more can we get? It was initially bedeviled with like you could not give a prescription and you had to get a doctor or someone who was close to the patient to get this, and those things have been ironed out now thanks to COVID. It still is not everyone's cup of tea. There are some I know personally some ID doctors, and I agree with them, is that you cannot make too much of a diagnosis from sitting across without actually feeling and touching and getting some feedback from the patient as to what is happening. This is in chronic illnesses. As far as acute illnesses, I have helped colleagues in other ICUs even start an ECMO or cannulate or do things via a means of not necessarily big telemedicine, but just somebody holding an iPhone next to the patient and me talking them through, or holding an iPhone in theater, in their theater, or any phone, smartphone in the theater, and I could see the images and I could give them some pointers. Of course, the person who was there operating is also a very senior surgeon, so they could understand those things. As far as the doctor-patient thing is concerned, I think this more than tactility, people talk a lot about tactility. If I could put my finger and I could feel his liver and so on and so forth, I think it is imaging, maybe on-site imaging and on-site vitals that I think somebody earlier on was talking about monitoring in ICUs, blood pressure, ECG and things like that. The problem is the quality of the images we get sometimes is quite poor. So if you could overall improve the quality of images transmitted from remote places, that would actually help extraordinarily to even more help these patients.
Absolutely. So I think that's where straight away I think we see two opportunities from a startup or entrepreneur perspective. One is, of course, everyone is talking about the impending 5G and how 5G telecom rollout will actually give really super high speeds and would be ubiquitous. So that is there. And the other, still being in a remote place, there may be engineering solutions which is required, which in turn actually can look at bandwidth compression or smart compression, so that even at if things vary or the bandwidth is not that great, but the resolution and the details are good enough for the specialist sitting at the hub, that they can make an intelligent diagnosis. Yeah. So it's really been a very exciting session, Dr. Paul Ramesh. Everyone is very appreciative of it. Maybe as a closing thought from your side, a word for all the startups and entrepreneurs and others who will get an opportunity to see this later offline. What are some of the big challenges you see in your domain, which can then in turn emerge as opportunities to the entrepreneurs? Because as they say, every challenge is an opportunity. So
Yes.
some views on that.
So I see quite a few challenges, but the most important challenge I see in delivering high-end critical care to patients in India is cost. So even the existing technologies, almost virtually all of it is imported. So I think as part of import substitution, if some of the startups can start looking into delivering not just as far as whether it's ventilators or ECMO is concerned, the steps are going to be, right now it's a fairly large machine which we had about 10 years ago. It's getting smaller. So one is the actual machine gets miniaturized. The other thing is it starts getting mobile, so you can take it, and both these things have happened, but they've happened and it comes at an extreme cost. So that is one of the things I think that you can definitely work on: existing technologies but lowered cost and same quality or near enough quality as those. That is number one. The second thing is in terms of as far as our country is concerned, is infection. And I think it is going to be a global problem soon, because once you get a resistant bug in one part of the world, it's going to travel very quickly. And so bacterial infections. And I was speaking to Muralidharan and his colleagues, Dr. Singh is the head of the Department of Chemistry, about starting, they already do medicinal chemistry. But one of the areas that is neglected is looking for next generation drugs. And a lot of pharma companies would be very happy to collaborate with you. And the third is a more general point, which I feel very passionately about, is that I think a lot of the startups should collaborate with basic science people, should collaborate directly with doctors, ICUs. You should come out of your comfort zone of your labs, and you should see what is really happening, because the human suffering is something else. Okay, there is a deeper emotional connection, which I think if you see, then you will probably invest more of time and passion into what you do, and you will also understand where your actual innovation is leading to. So I think you should form these collaborations either informally or formally, and I think you should come to hospitals and go to basic science labs, so that I think together only we can move it forward. There's a lot of things to be done, a lot of things, and a lot of talent in this country which can do it also.
Sure, absolutely. No, this is really the high point, and I'm sure this will resonate very well. And I think when the collaboration across sciences or across faculty start, then truly we can really evolve and create innovation, which is, I think, the core objective. So on behalf of all the participants and ITM STIC, once again, I really thank you for your time, your insights, and suggestions, and for motivating all of them. It's been a pleasure to have you. I hand over the session to Sumitra for closing it. Sumitra, over to you.
Yes, sir. Thank you, sir. So thank you so much, doctor, for spending your time with us from your busy schedule and sharing your insights with our participants. It was a brilliant session, which I would like to say. And I would like to thank Sanjay, sir, also for your time in sharing today's session. And I thank all the participants for joining this session. And one more thing, just I would like to check with you, doctor. As in a practice, we usually upload our sessions in the YouTube channel. I hope that is fine with you.
No, absolutely no problem. Please go ahead.
Yes, doctor. Thank you. And thank you all the participants. And we also posted a feedback form in the feedback form link in the chat box. So please do the feedback form, and it will help us to improve our sessions in the future. And thank you. And once again, thank you, doctor. And thank you, Sanjay, sir.
Thank you very much. Thank you.
Thank you.
Thank you so much. Stay safe, everyone. Bye-bye for now. Have a good evening.
Thank you, sir. Bye, sir.
Bye.